back, everyone. This is episode 4, and I'm really pleased to be joined by Hannah Hayter, who is the team lead for medicine and surgery at the Wye Valley NHS Trust. Is also currently an educator and guest lecturer at the University of Worcester, and really specialises in respiratory and critical care. So welcome to the channel and welcome to the series, Hannah. How are you?
Thanks. I'm fine, thanks, James. Lovely to be here.
Great. Yeah, it's brilliant to have you on. And you're our third instalment of respiratory placements.
Excellent.
I think it's a very well needed area and something that a lot of students stress about. So I think probably most of them. So I thought we'd put together several videos to alleviate some of those nerves. So can you just sort of briefly introduce what your role involves as sort of team lead and educator?
Sure. So I guess from a team lead perspective, Wye Valley Trust is a relatively small trust, and the hospital I work at is a relatively small district general. We have a general ITU and obviously a general respiratory ward as well, but it is one of our biggest ones. So I guess from a team lead perspective, I obviously have a relatively small team that I joint manage with another member of staff because I work part-time. And obviously our day-to-day is looking after the other staff that we manage. So we have 2 band 6s, 2 band 5s, a band 4, and a couple of other assistants who are brilliant, obviously, as well as students. But there's obviously a significant portion of my job which is clinical. So it's either going out and treating patients either in ITU or out on the respiratory wards or the medical wards, wherever we're kind of most needed, obviously supporting more junior members of staff, and then obviously doing quite a lot of teaching, which I really enjoy. I'm in charge of our on-call rota, as well as ensuring we get more staff and new members of staff onto the rota at the same time, and looking after the staff that we do have on the rota and making sure that they feel kind of happy and competent. So it's a big mix of kind of clinical and non-clinical work, which I really enjoy.
Fantastic. And fitting into that, obviously your role as an educator as well with students. And it is, from your point of view as you're teaching, do you find that complements your sort of enjoyment of teaching as well?
Yeah, I think so. And I think also from a lecturing perspective, I think it's made me a better educator because having a little bit more background knowledge as to what's being taught at obviously the university that's the most local to us. And it's really made me kind of concentrate on, obviously I've done a lot of band 5 and band 6 teaching over, I've been qualified for 13, 14 years now. But I think taking on the lecturing has kind of given me a really good boost in a sense that you have to teach in a very different way when you're teaching students, and obviously take into account that they may have very little background knowledge, so having to go properly back to basics, which I think actually has made me a better educator, because I've had to adapt the way that I teach myself, because obviously there's no one size fits all from a learning perspective. And it's also then appreciating that particularly where we are, I know that Worcester struggle a lot for acute placements. So we will quite often have third year students who have never set foot in an acute hospital. And it's making sure that we set the right expectations for ourselves as educators to make sure that we aren't, that we tailor their placements to what they've actually got from an experience perspective, as opposed to kind of thinking, okay, well, they're third years, therefore they should know X, Y, Z, they should have experienced X, Y, Z. And I think it's been really beneficial for me.
Brilliant. No, that's fantastic. Okay, wonderful. So today we're going to go through our 3 main topics, which is how to prepare, what to expect, and how to get the most out of placement. So we'll hit the first one running then. So in terms of preparing for placement, and this sort of covers obviously your first, second, third, and fourth years if you're in Scotland or things like that. And it was sort of your advice on what you would suggest a student does to prepare best for a respiratory placement.
I guess from a general perspective, all this goes for any placement, obviously not just respiratory, but I think because people are I was terrified when I did respiratory as a student, and ironically it was the worst placement I ever had, and it made me, I kind of came out of it thinking this is definitely not something for me, which given now what I do is really ironic. But it also made me think that I didn't ever want to make any students I ever had feel the way that I did. So So I'd always say make sure you get in touch with your educators before you start, and particularly because they tend to be more frightened about respiratory than perhaps some of the other specialties, just because the patients are sick and it's a complete unknown. And I think up until recently, even within the kind of wider world of physio, people didn't really know what respiratory physios did. And, that's probably the one thing that COVID's done for us, is kind of very much put us back in the spotlight, which obviously has had some huge benefits as well as being hard work at the same time. So yeah, always get in touch with your educators, because they will quite often be able to give you some pre-reading to do. It's good for us to know before students start perhaps what experience they've had. So again, like I said, we can set our expectations. So if we know that you are halfway through your respiratory module as a student and you've perhaps had one placement so far and that was community peds, it means that obviously we know that your respiratory knowledge rightly isn't going to be pitched at a particularly high level, so that we know that we can kind of nurture that as we go through. And even when we get to kind of end of second year, third year perspective, again, if we know what experience you've had before you've started, it makes it much easier for us to tailor what we can help support with, particularly in those first few weeks. What we've just done we have currently six students from Worcester, and obviously with the environment at the moment, we've tried to do as much of their kind of pre-induction-esque stuff online. So actually one of my colleagues and myself put an entire virtual induction together. And one of the things we got the students to do was to kind of look at the news charts and kind of be familiar with a lot of the things that we look at on a day-to-day basis, blood results, arterial blood gases, just so that when we started talking about their third years, I suppose. So again, I know that they've been taught critical care because I've done it. So I think it was the day-to-day things that we find that we go over with every single set of students, whether they're first years, second years, third years, fourth years, MSc, BSc. It's just kind of getting them familiar with what it's like working in an acute environment. And that obviously goes across every specialty. I think our students have, so I think if you haven't had an acute placement before, that's absolutely fine. But if you have got any resources, kind of look up some of the things that we chart. So the news score is obviously a national one, so that's always worth looking up. Going over any respiratory assessments you've ever gone through, any treatment techniques, any conditions, particularly the common ones. And I guess I always hark back to anatomy and physiology, because if you've got a good understanding of your respiratory A&P, it makes your clinical reasoning considerably easier, and it makes it much easier for us to be able to explain things like, changes in mechanical ventilation or choices about treatment options and escalation options. And I think that's one of the things, particularly when I was a student, that I think I didn't do enough of. I look back at how hard I worked during my respiratory placement and it was absolutely phenomenal, but most of it all came back to A&P. So I think it's always worth going over your anatomy and physiology, because actually if you understand the mechanics of the lungs and the gas exchange process, then actually so much more of the treatment options that you see, particularly with the acute group and the most acute group of patients, will make a lot more sense.
And then that links into helping with your clinical reasoning.
Absolutely.
Them as a student, if you can clinically reason, explain that to your educator, then you're going to do well. So a couple of key things there. So I always like to recap on some of this. So you've mentioned the news score there, and that's so for those of you watching this who haven't come across that, that's your typical observations that are carried out by the nursing staff on a regular basis. So your temperature, your blood pressures, your oxygen sats, pulse, respiratory rate, things like that. So get a good idea of maybe the normal values as well on that.
Absolutely. Just because if you know what normal is, then it's obviously much easier to be able to spot what abnormal is. And it's exactly the same with things like auscultation. Whenever I've taught auscultation, whether that's to students or whether it's to band 5s or 6s, in terms of from a revision perspective, I'm just like, well, listen to a normal set of lungs, because actually if you know what normal sounds like, then listening to abnormal consequently is much easier for you to be able to figure out.
Yeah, absolutely. I remember when I first started as a band 5, which still isn't that long ago at all. I remember I hadn't done any respiratory for a while, and I thought, oh, and I took my stethoscope and I used to auscultate lots of patients,
Yeah.
just to get that kind of your ear into what's normal and changes and things like that. So yeah,
Yeah, exactly.
I think I auscultated the dog when I was at university.
Ha!
So that's a really good one. So you mentioned your ABGs as well, your blood
Yeah.
gases, get a bit of an idea again of those. Some of your treatments that are a possibility.
Yes.
Good idea to have an awareness of those. And then your A&P. I think that's a good one that's come out today. So I think your A&P, so your anatomy of the lungs and how they work, and with the, would you
Yeah.
say alongside the cardiopulmonary system, which you sort of include a bit
Yes and
more?
no. I think it depends. So, I mean, I never remember being taught a huge amount about the cardiac pulmonary system when I was at university. I've done a lot of self-directed study around it since I've been qualified, and particularly since I've specialised in critical care, just because I don't like not knowing things, and particularly working in intensive care when you're kind of learning about some of the supportive drugs that we'd use, things like inotropes, which will obviously support your blood pressure. It kind of wasn't ever enough for me to know that they were drugs that we used to treat certain conditions. I kind of needed and wanted to know why, and physiologically why, and what they did. So that's something that I've definitely gone away and looked at since I've been qualified. And again, I think my expectation of a student would be that I wouldn't expect them to come with a huge amount of that side of that knowledge. Obviously, if you're thinking about, you know, if the implications that if the heart isn't working properly, how that might affect things like your oxygenation in particular, having that kind of knowledge of that relationship is really important. But I think in terms of looking at your clinical reasoning for specific, or very specifically to respiratory, it would be your mechanics of your normal respiration, and it would be your gas exchange process that I would really like to hope that people could kind of properly get to grips with.
Brilliant. Okay, would you say as well, is sort of, I mean, having a good look at this stuff before you go on placement, and if you get to placement and you're still not quite sure on some of those things, having some good questions to go into placement and say, this is the stuff I've
Yeah.
been doing, this is the stuff I'm not sure of, I'd love to use this placement to really get to grips with it. That'd be something you'd like from a student, would you say?
Oh, absolutely. And kind of when I sat down with our current students and kind of went through their induction in person, I think we'll probably touch on this a little bit later, but as educators, we are an absolutely fantastic resource for students, in the sense that, you know, we've been there, we've qualified, and we've been working for various lengths of time depending on who your educators are. And actually, for us as educators, you asking us questions shows that we know that you're interested, and that you're engaging in your placement, which, particularly if you're perhaps a little bit shy, or you aren't a particular extrovert, is really useful for us to be able to kind of have a bit more insight into the fact that whilst you might not look like you're enjoying your placement or taking much of it in, actually you really are. Because if you come to us with questions, we know that what we're teaching you and what you're experiencing is properly kind of there. It's not that you're just not interested, because I appreciate that respiratory is not everyone's bag, and whilst it very much is mine, I equally remember that when I was a student, respiratory was not my bag at all. And that's only really come since I've qualified. So, but I think, yeah, asking questions definitely, and equally coming with questions, shows us that you've done your prep, and that you are properly engaged, and are equally going to make the most of the experience that we can offer you as well. So I think that's really important.
Brilliant. And it also, the other thing I was thinking, it takes the pressure off a little bit, that it's already quite a scary placement to go sometimes. And then to feel like you need to know all of this stuff,
Yeah.
actually having a good awareness of it, but being aware of what you don't know is actually just as
Oh,
important.
absolutely.
Yeah.
And I think I always say this to band 5, that's the one thing we can never teach you, both at university and when you've qualified, is what your limitations are. And it takes a lot of courage, I think, particularly when you're first qualified, to kind of really own up to what you know and what you don't. But as both an educator and someone who supervises more junior staff, actually, if I know that you know what your limitations are, my concerns around patient safety are zero,
Yeah.
because I know that you're not going to put either yourself or the patients in any kind of harm or harm's way, because actually you're not going to work outside of what you think you're comfortable with. I worry far more about students and junior members of staff who perhaps don't have that quite same awareness, because I'm slightly more like, oh, do I trust you enough to be able to go, and that sounds awful, but it is true, and it isn't something you can teach particularly easily. So equally, I think if it's something we can be honest about, particularly as you're going through the university process, and actually being aware of your limitations is actually a strength, not a weakness.
Absolutely.
And it makes you a much safer student, and it makes you a much safer member of staff as well.
Yeah, definitely. It's a real eye opener once you get that. I think it does come with confidence as well, because
I agree.
being in this day and age that we live in nowadays, saying I don't know that or I'm not good at that is not something that's pushed enough, I feel, as
No, I
a
agree.
so yeah, students out there, shout about what you don't know and what you want to know more about. Brilliant. And that's a really, really good overview of how to prepare. So we then move on to what to expect. And I think for me, this is often one of the things that drives a lot of the anxiety, because of
course,
like in anything in life, if it's an unknown, we're usually quite worried or scared about it. So I thought we could try and unpick some of the things that you might see and do on a respiratory placement, whether that be sort of critical care or on the wards. So we have what's the sort of first things that come to your mind as a student might see and do?
I guess thinking really on a basic level, you're going to see patients in beds. If your only experience so far of anything within the physio world is outpatient type, whether that's neuro outpatients, MSK, or community, that is probably one of the biggest differences, is that you'll see patients in beds, hopefully in chairs, but primarily in beds. They may have a lot of wires and attachments. At the same time, there might be a lot of monitoring going on, so it can be quite noisy, particularly in intensive care. I remember when I first started in ITU as a band 5, I swear, even when I went home at night, all I could hear was the alarms going off in my ears. So yeah, it's noisy. So I guess that's one of the first things, is the fact that, and patients will look unwell. Even the ones that aren't even that unwell, they won't look well.
Okay.
So that's probably one of the first things. And then I suppose, depending on the degree of how unwell they are, will depend on how many attachments they have, and whether or not or how much support they're needing from us as medics. So thinking obviously specific to respiratory, are they on oxygen? If they got nasal cannula in their nose, if they got a face mask on, are they having to have slightly more support? So are they on CPAP or high flow nasal oxygen or non-invasive ventilation? And then obviously within critical care, you've obviously then got patients who perhaps are ventilated. So are they ventilated with an ET tube? Have they got a trachea? Since COVID, we've been using the CPAP hoods a lot more, which make people look like spacemen, which again, I haven't seen for donkey's years. But yeah, I guess a fairly kind of general rule of thumb is the more attachments they've got, probably the sicker they are. Not always true. Some of that monitoring might be routine and is being done for a specific reason. So yeah, I guess the patients will look unwell. They may well have a lot of things attached to them. And I guess then that obviously will have quite a big implication from a communication perspective. So, when we ask students to go and get a history from a patient, it might well be that patient can't tell them what that history is. So you either have to think about phoning the patient's family, making sure you're really thorough about going through the notes, speaking to the nursing staff to perhaps see whether or not they've been able to take a history from the patient's family, so that you can kind of still get all of those questions answered, but you might not be able to get them from the patient. Right. What else to expect? I guess if I try and think about like a normal day for us, so we regardless of whether that's on intensive care or on our respiratory ward or another medical ward. We'll always go and get handover from the nurses. So we'll get a general overview of all the patients on the ward. Obviously, we'll ask much more specific questions about patients that we either need to be seeing, sorry, or patients that we are already treating, to find out how they've been. Has anything changed? You know, are we getting to the point where actually they might be able to be discharged? You know, much like you would on any other ward, really. And then we would prioritise, because there's usually more patients than you've ever got hours in a day to be able to see. So obviously we then prioritise our patients in the sense that those who are the most dependent on needing physio input, whether that's for a new assessment, whether it's for ongoing kind of chest clearance, whether it's because actually we're kind of rehabbing them and they're quite close to being able to go home, they are always our biggest priority. And then our slightly more rehabby patients are perhaps ones that either we could delegate to our really brilliant assistants, or equally as a student, you might end up having that kind of cohort of patients, hopefully that you've perhaps been able to follow through from when they've not been particularly well, to then kind of getting them to a rehab stage before they get to go home, which obviously is really great from an overview perspective. So yeah, we prioritize the work, and then we kind of work through the lists that we've got. Obviously, that work can be delegated in the sense that it's not always just you. So it might be that, you know, if I was on our respiratory ward, for example, I've usually got a band 6 with me at the same time, plus or minus some of our assistants, plus or minus a band 5. So there's quite a few of us that we can get through the work with. There might be patients we want to go and see together because they're either a little bit more complicated, or they provide really good teaching opportunities. So that's kind of thinking about our respiratory ward in particular. I guess in intensive care, because we're quite a small ITU, we have a fairly blanket referral system, in the sense that we will probably cast an eye on all of the patients. So we, again, in terms of what order you see those patients in, will very much depend on the handover you've been given from the nurses. Some of them might need lots of intervention from us, in the sense they need lots of chest clearance and or lots of kind of limb exercises, because perhaps they are sedated and ventilated. So you kind of almost taking the place of being that patient's kind of limbs and muscles, because they can't do it for themselves, plus or minus the chest clearance stuff that might come with that. Obviously with the added complication of the fact they perhaps are ventilated, even if they've not an underlying respiratory problem. Or equally, sometimes the patients are not stable enough for you to be able to do very much at all. So other than having a conversation with the nurses, perhaps doing a really gentle assessment of their kind of limb range of movement, just to make sure they're not getting any joint restrictions, and or assess their chest, there's probably not very much more you can do, other than if we've got scope to probably help the nurses reposition, particularly at the moment. So again, that whilst that workload is fairly static, in the sense that we would probably try and see all of the patients unless there was a good reason for us not to, our intervention or level of intervention will very much vary from patient to patient. Whereas perhaps the ward is a little bit more predictable, in a sense there'll always be new patients for us to see. There'll always be patients who are new, kind of needing their airway clearance techniques, you know, whatever they are, and or ones that we're rehabbing at the same time. So I guess that's probably like a routine clinical day. And then in terms of kind of what you experience within that, will probably very much depend on where you're working, and kind of particularly whether you're in or out of critical care, just because the patients will obviously look very different. But I guess we do what you do in any other field of physio. You do your assessments, you do your treatments, you check your problem list, and then obviously you plan. And you go from there.
Brilliant. So, and that's bringing it round back into what I think we've covered in a few of the other of this series, is some of the basics are often exactly the same, not exactly the same, but very similar to elsewhere. You're not reinventing the wheel and going into something crazily different.
No, I think it's just about we just have slightly different tools in our toolboxes with the patients that we see, and depending on whatever specialty that you happen to either be working in or you have a placement in, your assessment skills are exactly the same in the sense that your history taking, your objectives they're always the same. There'll just be a few subtle differences depending on what area you happen to be kind of specializing in or working in, whether that's respiratory, neuro, MSK. There might be some slightly more kind of special tests that you do in certain other areas, or equally different bits of information you'd look to find, depending on the patient and depending on where you are. But your actual kind of broad assessment skills are exactly the same on every on every kind of area that you might work in. And I think that's probably one of the biggest things to stress, particularly to students who are coming to do respiratory, is yes, the patients are sick, so therefore it is can be a lot more stressful. But actually, even if you are, it's your very first placement, you will still have some of the skills that you need to be able to do an assessment on a patient.
Yeah, definitely. And when you run placements, those tweaks are the things that you're going to come out of the placement, aren't they, as well? Those are the things
Exactly.
you're going to learn.
And for you to learn and be taught as well. I think as educators, I think it's always really good for us to be reminded that we are there to teach at the same time. I think one of the things that I struggled with the most when I did my respiratory placement about 100 years ago, was that I think I went into it with the expectation of being taught, and my educators had the expectation that I should know it all already, which is why perhaps it didn't go quite so well. And I'd done my background, but perhaps not as much as I could have done. Like I said, particularly as if I look back and look how hard I worked during that placement, particularly in the amount of kind of reading and stuff that I went around and did, and the amount of learning I did. Actually, whilst it wasn't particularly pleasant at the time, it was a really valuable learning experience for me. But yeah, we are there to teach at the same time. And yes, whilst you do need to be able to experience what it's like being a physio, because I think, university sometimes is a little bit like learning to drive a car, in the sense that you go to university and you do driving lessons to learn how to pass your driving test, and you learn how to be a physio once you've qualified. It's exactly the same. You learn how to drive a car really once you've passed your test, and you learn how to be a physio once you've actually kind of finished your degree, because then you get a little bit more kind of free rein to learn how you want to be a physio. And that, the best way that we can kind of teach that when you're at university is by being out on placement. So like I said before, as educators, our roles really are to teach you and fill in the gaps where you kind of don't know quite so much what to expect, but also to provide you with it of what being a physio in that area is also all about. Yeah.
No, definitely. That's brilliant. So in terms of getting the most out of placement then, so there's a really good overview, I think, of a picture of what to expect on placement. But getting the most, what sort of advice have you got from an educator's point of view? As a student, what can they do to get the most out of that placement whilst on placement?
So I guess we've kind of talked about asking questions already, because actually, for us as educators, that's a really useful way of us knowing that you're really engaged in your placement. And like I said, because we are, we, not just your educators, but the other kind of physios and assistants you might be working with, are really useful resources, because we are doing that job day in, day out. So if you come to us with questions, you never know what you might learn, because actually there'll be things that our assistants will tell you, which will be utterly invaluable in terms of, manual handling and how to talk to patients, and like make the most of every member of staff you've got you can be in contact with, really, because there's always the opportunity to learn. I think it's one of the things I love the most about being a physio, is that even, I've been a band 7 for quite a few years now, and obviously I've been qualified for a long time, is that there's always opportunities to learn. And that's one of the reasons that I enjoy getting up and going to work in the morning. So do your homework, ask questions, and I guess also appreciate that the environment is a resource to you. So whether that is, setting kind of spoke days to, go and spend a day just with one of the nurses on intensive care, not necessarily to do anything physio specific, but just to learn what it's like to be there for a length of time, or equally, shadow one of the nurses on the ward, or HCAs. I think sometimes like just learning how to be around patients can be quite challenging.
Yeah.
And actually, if you've had the opportunity to just not even have to think about physio stuff, but just kind of be around patients and make it a little bit more relaxed and informal, that in itself is really valuable.
Yeah.
And then obviously slightly more specific respiratory wise with these spoke days, is there an outreach service that you could go and shadow? Could you spend some time with perhaps one of the anaesthetists or one of the consultants in their outpatient clinics? And just so you can get a really good overview of what it's like, because obviously respiratory covers both covers your acute stuff, but also your management of your long-term conditions, whether that's in the acute environment or equally in the community.
Right.
Our consultants look after both of those groups of patients because we are a small trust, so we have a lot of our outpatient services that are still managed by the consultants, who then would see you as an inpatient as well. So there are a lot of other services, so you've got your kind of clinical nurse specialists who would look after both groups of patients, and your advanced practitioners. So there are a lot of resources within the hospital outside of physio that you could use to make the most of your placement. But again, being engaged and kind of doing your research a little bit into, even whilst that's, if that's whilst you're on placement, about the kind of services that are offered in the hospital you happen to be working at. If there's something that you find particularly interesting, tell us.
Yeah.
And we'll see if we can organise you a spoke day. If you're on surgery, do you want to go to theatre?
Yeah.
And we're really lucky. All of our intensivists love teaching. So if they're ever going to do rapid sequence induction and that we happen to be around, they always ask, does anyone want to come and help? I remember one of our consultants, when I was quite a newly qualified band 5, was going to do a bronchoscopy, and he's like, do you want to come and watch? And I was like, yes, obviously. And it's just little things like that. So and everyone you come into contact in a hospital is a resource. So make the most of them.
Definitely.
That's probably it, really. I think it's quite difficult to give an overview in too much detail, because obviously so many hospitals and so many trusts are different, but those are the kind of things that will always be the same regardless of where you happen to be out on placement. Use the people you are in contact with to make the most of the experience. We run lots and lots of teaching sessions for our band 5s, and if there's one that, even if it's not that specific to your placement, but it's something that you're really interested in, ask to go to it. So I think that's probably my best.
No, I think it's great. I think it comes back to being engaged in the learning process, and it's not there. I always say you don't just go there to be sort of have everything given to you. You will get some teaching, but you'll get much more out of it if you're a bit of a pest actually, and say, "Oh, can I do that? Can I? What's this? What's that?" And also, if you come across in the notes, I always find if you sort of think, "Well, what do they do?" Actually, rather than trying to work, you can say, "Oh, actually, why don't I just go and spend the day with speech and language?" And that'll give you much more of an overview while you've got the opportunity on placement in the hospital, which you don't get whilst you're at university.
No, exactly. And like I said, it is about having that understanding of particularly the multidisciplinary aspect of I think ITU is probably one of the best examples of that, because so obviously some of the patients are so debilitated that we as medical professionals have to take over every single one of their day-to-day, what's the word I'm looking for? We have to do everything for them. We have to be there. We have to be their voices. We have to be their movement patterns. We have to be their airway clearance techniques. We have to do everything for them. But that isn't done by just one person. It's done by a huge collective of people working together to achieve the same goal. And I think that's probably one of the things that I love the most about working in inpatients, is the fact that you are part of a big team, and that big team has got lots of different skills, but they all work really beautifully together. And like I love working as part of an MDT. I love being able to learn off my OT colleagues and the speech and language colleagues and my medical colleagues and the nurses. And I think that's one of the reasons that I, particularly in critical care, enjoy it the most, is the fact that actually it's one huge collaborative effort to get the patients well and to kind of get them achieving either their previous level of function, or if they're recovering from something that's meant their function is significantly has been significantly lowered, trying to get them to improve on what they were already doing, which, you know, is from a rehab perspective is so satisfying. So yeah.
That's brilliant. No, I think that's, yeah, for me, that's hit the nail on the head of what I find on inpatients is that teamwork. And when you can get everyone together and use everyone and work together and communicate well for just that one patient, it's an amazing satisfying, especially when you get the outcome that you know is what the patient wants.
Absolutely.
It's brilliant. Really, really good. Well, Hannah, I think that's been brilliant. Actually, it's a really, really good overview, but actually there's some really specific things there that people can take away to prepare and to do on placement to get the most out of what is a fantastic area of physiotherapy.
It really is, I promise.
Yeah, it's not as scary as it seems. It's brilliant, but you've given some real insight into how to kind of get onto placement feeling a bit more confident and also get a bit more out of it. So thank you so much for joining us.
You're welcome.
Giving us your time, and you never know, we might have you back on at another point to go through some of the more specific things as well.
That's fine, I'd love to.
Lovely. Thank you very much, Hannah.
Thanks so much, James.
Take care.
Bye.